So we shall go on to the next session, my ideal choice in ocular aesthetics. And we have Dr. Shilpa talking on my ideal patient for Botox. And she is a senior consultant, facial, plastic and aesthetic and ophthalmic surgeon from Delhi Eye Center, Delhi. On to you, doctor.
Good evening, everyone. Thank you, ma'am. And when this opportunity of speaking at AIOS was given to me to speak on my ideal patient for Botox, the first thought which came to my mind was patient who's willing to get a treatment and who's willing to shell few bucks is my ideal patient for Botox. But then I thought that I have to speak something for 10 minutes, right? Starting just a little bit about Botox, because when we say my ideal patient for Botox, we really don't mean Botox only, which is by Allergan. We mean botulinum toxin. So the type A botulinum toxin, which is the most potent, as Dr. Kasturi also mentioned, and the three major botulinum toxin A formulations which are available in the market and are most famous, Botox, Dysport, and Xeomin are most commonly used. Apart from that, the type B Myobloc is also used when it is required. And there are then many others, as has been discussed previously. Botogeny being the most commonly used, similar, I would say. So what's in a name? We have actually discussed this, so I'm not going into detail. Why I had put this here was because I'm going to use the application of botulinum toxin, and mainly why we want to study these different types of Botox is that first for safe clinical practice and to achieve optimal consistent results, as Dr. Shubra also mentioned, we need to understand the clinical issues of potency, conversion ratio, and safety issues of each toxin available in the market. And as far as the key players are concerned, I would say Allergan is the key player, and I don't have any financial interest. Coming to choice of patients and my ideal patient, when to use botulinum toxin and why, when not. So the wrinkles on face, they do not look as cute as this on everyone, as we all of us know. So the facial rhytides, either dynamic or static, would need smoothing. We will not use the botulinum toxin where patients have peripheral motor neuron disease, amyotrophic lateral sclerosis, motor neuropathy, other neuromuscular junction disorders like myasthenia, Eaton-Lambert, in cases of pregnancy, areas of active infection at the site of injection, and any previous known hypersensitivity to formulation where we can change to a different formulation altogether if it is required. So reconstitution of Botox has already been discussed. I just want to mention here that if the vial is not opened previously and the seal is intact, then while you're making and preparing the Botox, while it is reconstituted, the plunger will go automatically in because of the vacuum inside the vacuum seal right package.
Mentally, physically.
Please,
I would just request
on mute.
Yeah. And after we have reconstituted the Botox vial with non-preserved normal saline and only normal saline, not distilled water for injection, prepare your syringes. You can use tuberculin syringe or insulin syringe as preferred. Some pre-injection procedures. Do a thorough pre-procedure consultation with the patient as to what patient wants. Consent to the treatment, a written or a video consent will be preferable. And pre-procedure photography, because patients usually forget later how they used to look, and small changes which are previously there on right and the left side which don't match, they blame it onto you. They might blame it onto you, and record your treatments if possible. And general principles of injections, anywhere, wherever we are giving, upper face, mid face, or lower face, apply Prilox to patient's face around half an hour, 40 minutes before. Give ice treatment, which will decrease pain. while you are starting the procedure, clean with alcohol swab. Ask patient to animate always before the patient when you inject. Assess again, inject, avoid thin blood vessels so as to avoid any ecchymosis, and call patient back after 2 weeks, because usually it is then when the effect of Botox will be properly seen. Aftercare, I usually tell the patients not to lie down for 4 hours for the risk of spread of botulinum toxin. Don't rub or massage vigorously for a day. Don't do rigorous exercises, and don't use blood modifying agents. Don't take green tea, vitamin E, aspirin, etc. So patients who are having upper and mid face indications usually will have forehead lines, crow's feet, glabellar frown lines, bunny lines. When we need to do chemical brow lift of the eyebrow, and lower lid injections when it is needed. So we'll come to each one of them one by one. Here I'll be sharing few patient photographs. This is the lady. As we see here, she's smiling slightly as in static. And in this dynamic phase, we can see the horizontal forehead lines, the crow's feet, the wrinkles, and see the prominent nasalis here in this patient. Again, this lady in animation shows a single frontalis muscle. Here, the frontalis muscle is a broad base, we can see, and prominent glabellar lines. Again, corrugators we can see very nicely here. And in lateral picture, the crow's feet are also seen. Again, this patient, when she smiles, the crow's feet are nicely seen. So customize the treatment. This patient does not need that much forehead Botox as this patient, and this patient on the right will not need nasalis injection, but this lady will need nasalis injection as well. Again, this lady has more crow's feet when she is not even that much smiling, and this lady has very less number of crow's feet. So the number of injections to be given here and the number of injections which will be given above the lateral canthal area in this patient on the right and the left will differ. Coming to horizontal forehead lines, as we all know, the only elevator of the brow is frontalis muscle, and it contracts and gives horizontal forehead lines which are perpendicular to the action of contraction of the muscle. So this is the basic rule. And here this lady again. Ask the patient to animate, inject into the belly. While giving frontalis forehead injections, just go in 2 to 3 millimeters, as there is frontalis muscle just below the skin and small thin subcute tissue. And do not inject a finger breadth above. Do not inject within the finger breadth here from the eyebrow, because it is the only elevator of the brow. And if we inject in all the right sides here, then patient might not be able to elevate the brow when patient needs to. So usually I inject above the first right eye which I see in the patient. Coming on to glabellar lines. Sorry, I forgot to mention the dose here. So at each site, I inject 2 units and spaced well apart, because we have to consider the circle of diffusion of Botox, which Dr. Raman had mentioned nicely. And it's usually 1 centimeter. So you can initially in the practice mark also the points wherever you want to inject on the forehead. This is the usual pattern we mark the forehead in. Coming on to glabellar lines, which are usually formed here in the center because of the action of procerus muscle here and the corrugator muscle on both sides. So the depressors of the eyebrow, the procerus and corrugators, will cause formation of 11s, the glabellar lines. Pinch the muscle before you're injecting. Procerus is a thick muscle. When you go in a half needle length, you will be needing to go in to inject. After you go in, you can aspirate Botox, if given in blood vessels, will not cause any harm as it's a neuromuscular toxin, but aspirate or just inject into the procerus hair. Coming to corrugators, it has two heads, the superficial and deep. So for the deep head, which is medially, one would need to go whole needle length in and inject. For the superficial head, go in a half needle length and inject. And if you ask the patient to animate, you will know how the corrugators are placed in that patient. So corrugators can be placed like this in this manner along the eyebrow, or they can go run up also at an angle of 30 degrees to the eyebrow. Coming to the crow's feet, the action of orbicularis repeated over years will lead to crow's feet here near the lateral canthus. And if, as I had mentioned before, if the crow's feet are more above in this area, just inject above. Otherwise, inject below the lateral canthus and above the lateral canthus, both. In this patient, I'll be just needing 2 injections for the crow's feet. Again, of 4 units at both the sides. For glabellar and for that is for procerus, corrugator, all I had injected 4 international units at each site. Bunny lines. So the ones which are formed because of the contraction of nasalis muscle. I'll be showing you this video after a while, because while I was incorporating it into the slideshow, it was not getting fairly well. So inject for nasalis here. Either you can inject in the center, 4 units either on each side. I usually just inject either on each side. So coming on to lower face injections for botulinum toxin. The muscles on the lower face, most important here around the lips, orbicularis oris, will lead to perioral area wrinkles, marionette lines here, and masseter hypertrophy is a very good indication of use of botulinum toxin in the lower face, as well as platysmal bands in the neck. For perioral lines, these are the points to be injected. Inject superficially, do not inject deep. Inject 2 units each, not at the wrinkle, just in between the wrinkles. For dimpled chin, we would need to inject in mentalis. For this also, I'm going to show a video later on. And I usually inject 4 units on each side of botulinum toxin for this pseudo-orange appearance of the chin. Again, for platysmal bands, we can inject. Either we can hold this platysmal band and inject into the platysmal band, or just inject without holding it. Either ways it would work. Inject superficially into the bands at multiple levels, 2 units at each point.
Should you be concluding? I think your time is running out.
Yes, ma'am. Yes, ma'am. So inject as the anatomy dictates. Just beware, because injecting Botox not properly commonly can cause spock eyes. When we inject the forehead here and the lateral muscle is unopposed, it will lead to spock eyes. It can lead to upper lip asymmetry if zygomaticus major minor are injected. Lower lid ectropion, ptosis, brow ptosis, and don't completely paralyze the only elevator, which is the frontalis. It may also cause chipmunk faces, where there is this appearance of unnatural resting face. If we have injected very low down in crow's feet area, this fat bulge will be seen lower down and the cheek will appear low, as in chipmunks. These are few pictures of my patients who have had combination treatments, because Botox alone would not work so well and patients would need good results. So I would want to say that if you use judiciously with proper techniques, Botox is definitely a wonder tool. And I would like to conclude by saying that my ideal patient for Botox a patient who is self-motivated, who comes to you, we are able to counsel the patient, is ready to look good at a certain cost, both material and emotional, and understands the limitations of the procedures. Thank you, all of you.
Thank you very much. Thanks. A wonderful talk. Just have two basic questions, and I'll take one with Dr. Millen. Now, when you give these injections, which part of the face has more predictable results?
All parts have predictable results, ma'am. Botox usually is used for upper face and lower face. Mid face usually doesn't have those many indications as such.
Dr. Millen?
Yeah, I would agree. Upper face is the most predictable, and the indications are also most popular, especially for an ophthalmologist. Mid face and lower face relatively less. I usually stick to the upper face.
And how do you deal with the pain component to make it less?
Well, pain part, you can either use prilocaine cream, which we also use for injections when we do the facial spasms. You can also use ice. I find cream application 20 minutes prior to the injection quite useful for patients. But frankly speaking, many patients are not willing to wait for those 20 minutes, and they don't mind being pricked with a fine needle. So pain is usually not a concern with at least half of the Botox patients.
Dr. Shukla?
Yeah, ma'am. So coming to like the areas of indication is aptly said for ophthalmologist upper face, but in my practice, I'm doing a lot of mid and lower face because that's where the major contouring happens. You can take care of expression lines on the upper face, but if you really want to contour the face, it's the mid and lower face which works the best. Regarding the pain, I think, yeah, those are the tricks. You know, I usually give Prilox or Prilocaine to people if I know that the patient is coming on a fixed date and time. I just ask them to buy the cream, apply at home, come and, you know, just inject and send them. And along with that, I think fine needle, ice, everything works together. Also, I think I would just add and ask Shilpa on that. Shilpa, which needle were you using, number one? And number two, I just saw your video of the upper face where you were injecting in a direction which is usually, you know, I saw it being injected in a different manner. So do you have a specific reason of why you were injecting towards the eyebrow on the forehead versus what we usually recommend is in the direction of the muscle, perpendicular to the muscle? Was there a specific reason for that?
No specific reason, ma'am. Just for this patient, the patient was at 45 degrees angle on an ophthalmic chair and I was standing on the head end. And plus, when we inject, if we leave the one finger breadth above the eyebrow, usually the diffusion circle is not that much to diffuse to all the unwanted areas, I must say.
Mm-hmm. So, and which needle were you using?
I was using 26 gauge. And like when I'm using a 1 ml syringe, 26 gauge comes with it. So I usually inject with 26 gauge. And when I'm changing the needle, I just shift to 30 gauge when I refill the syringe. So this is what I usually do.
Okay, so coming to the pain question, I think it is very important to use the right needle in addition to the technique which is being used. I find 26 gauge needle is more painful and difficult to penetrate, especially in a thicker epidermis, because most of the patients, especially the male members, have thick epidermis. So it is difficult to penetrate. And coming to the diffusion circle, just for the interest of the audience, and Dr. Kasturi, Adit, anybody who wants to add, Millen, please add. 1.3 square centimeter of diffusion circle will always be there, no matter in what area and how you inject. But I think the key here is to stay perpendicular to the muscle and you massage in the direction of the muscle. And I think for Botox, if you don't aspirate, it's fine, because when you aspirate, you already are with a fine needle in a small muscle group, and you may actually kind of, you know, deviate from the path where you're injecting. So these are just fine tips which can actually make the process very comfortable for the patient. But everybody has their own ways and techniques, so nothing right and wrong, which is some of the observations which I thought I would share. Dr. Kasturi, Millen, Adit, please add on to the things. Yeah, Shilpa, you can go.
I would like to add something on the pain part. So pain actually happens when the spread of muscle happens after we have injected Botox. The pain of prick is usually very less. We can eliminate the pain of prick by Prilox as well as the ice packs, but the pain which will happen once the Botox goes inside the muscle, no one can decrease that pain unless the patient is under GA, I feel. So, and we are not going to do this procedure under GA. So, as Dr. Chitra asked, the pain part is mainly when the Botox goes in and not when the patient is pricked, actually. This is what I wanted to say.
And these unwanted side effects is largely because the plane of injection is wrong. You need experience. These don't happen once you have reached a level of expertise.
Ma'am, after reaching a level of expertise, also they can happen because once you are so confident that nothing is going to go wrong, then only the things start going wrong. Initially, when you're doing everything according to rules, usually things will go right.
Okay. Any other question, or shall we go back to Dr. Aparna's talk?
I just wanted to tell you about the type of needle which I used. I definitely use the smallest size, which is on the insulin, which is the insulin syringes being used for injecting insulin rather than this tuberculin syringe. Yeah. Even this 30 gauge needle comes with a hub. So there's a lot of amount of approximately 0.6 ml, 0.06 ml goes waste inside the hub of the needle. So when you inject with the insulin syringe, one, the needle size is very less small, the gauge size is smaller, and you don't waste the insulin, the Botox. So I use those red syringes, which are meant for insulin injections.
So while that Botox is left in the syringe, if we aspirate little air and then inject, the Botox will go in and air will stay in the syringe. So that way we can stop wasting Botox in those syringes. This is what I've experienced.